Hey everyone, today we're talking about chest trauma, and we first need to start understanding the difference between closed chest trauma and open chest trauma. So that's where we're going to start first. So with closed chest trauma, what do we have here? Well, I think about a few different things. Cardiac contusion, lung contusions. When I think of a closed injury, what I mean is the skin is not open, it's not exposed. Let's go a little deeper here. So with closed chest injury, the skin is not broken. It is generally caused by blunt trauma. So what's an example of blunt trauma? Let's say I'm driving a car and let's say I'm unseatbelted and my chest moves forward and I strike that steering wheel. That would be blunt trauma. A baseball bat to the chest, a baseball, a golf ball, right? Anything like that to the chest. That's blunt trauma. Open is more penetrating. More on that in a moment. Now, here are some examples. Hitting the steering wheel in a motor vehicle accident. It can cause contusions to the heart and the lungs. What are our two big organs that we have in the chest that we gotta watch out for? When we got one heart and we got two lungs. Lungs, heart, right? So here is the big problem that we have. If we have an injury to the lungs, to the heart, we're talking about pumping blood with the heart, breathing in and out, ventilation with the lungs, those are life-threatening conditions. This is why chest trauma is very sinister and the patient can decomp more fast. Okay, now, cardiac contusion. The heart may have difficulty refilling with blood, or the blood is not pumped out effectively. Essentially here we have a weakened heart. That's what we get. The heart under trauma is a contusion to the heart. It's not at its full pumping potential. That's all we're saying here. So this leads to decreased tissue oxygenation and possibly cardiogenic shock. Oh, we got a big word there. Cardiogenic shock. What is cardiogenic shock? Well, what that is, it's the heart's fault. So what we're saying here, folks, is if we have a really bad cardiac contusion, could it lead to the worst outcome of cardiogenic shock? It could. It's definitely possible that it could, okay? Cardiogenic shock means it's the heart's fault. Why? We're not pumping enough blood and oxygen on the body, and our blood pressure is so low. When our blood pressure gets so low, I can't get blood and oxygen to all my different organs in my entire body. It won't reach. Lung contusion. This may cause the alveoli to not function. Well, the alveoli, what's that? The alveoli is where we bring in oxygen and where carbon dioxide is going to leave the body. It's where gas exchange occurs. Oxygen and carbon dioxide are gases. So at the alveoli level, I think about it as that's our lily pad, if you will, where all the action takes place. The alveoli, if it's not functioning correctly, we're going to have ventilation issues. Moreover, let's talk a little more. Rib fractures can also pierce lung tissue underneath the skin, causing internal bleeding. Again, it's traumatic, but you're going to see this in EMS. Let's say someone was assaulted with a baseball bat. Maybe you're watching a video, you've been on call with it before. You've seen this. We have broken ribs. The worry about broken ribs, are they painful? Yes. Is it an emergency? Yes. We're concerned. My ribs are here, folks. What do we have right next to the ribs? Our lungs, which is everything to us. Yes. So a broken rib could pierce the lung, and now we have air escaping the lung. That's not good, right? So it's possible that those broken rib fractures or lung contusion could cause hypoxia, low oxygen levels, okay? Again, what else do we look for in closed injuries? Rib, sternal, or clavicle fractures, okay? Our clavicle, sternal, middle of the chest, ribs. Now, a few pearls on that I want to give you about these three types of fractures. A rib fracture, it's a lot easier to fracture a rib than it is your sternum. Why? The sternum is so strong, it's such a big bone. It takes a large amount of force to fracture your sternum, okay? The clavicle is in a very interesting spot, but it still obviously could be hit, okay? It's a little more exposed. The sternum, If you fracture your sternum, there must have been a high MOI, which is a mechanism of injury, how much force was applied in that trauma, okay? Now the last thing here, and this is, again, high mechanism we think about, traumatic rupture of the aorta. So if you're in a car accident going 100 miles per hour, not wearing a seatbelt, and your chest flies straight into the steering wheel at 100 miles per hour, unseatbelted, yeah, I mean, it's possible we could have some of these, sternal fractures, rupture of aorta. As the mechanism of injury gets greater, which is why we talk about it so much in class, then what happens? We get worse of an emergency in a more critical patient. So now we're talking about an open chest injury, hence the name. This is not blunt trauma. Closed injury, it must have been blunt trauma. Open injury, it's going to be penetrating trauma. So here it is. Again, generally caused by penetrating trauma, breaking the skin. In open chest injury or chest trauma, what we've done, we've broken the skin. That's a knife, that's a bullet, right? Lacerations involved. So let's just break this down real quick. So this causes instant damage, but the symptoms may occur gradually. Remember, folks, in the body, a big pearl for you, even in head trauma or any trauma throughout the body, bleeding inside the body, it can happen fast or it can happen slow. It depends on what kind of vessels that we are encountering and we hit, right? So that is something to keep in mind. An example would be internal bleeding or pneumothorax. A pneumothorax can develop a little slowly, right? Or it can go into tension. We'll talk about that in a little bit. If the object penetrates the chest, it may stay there. It's an impaled object. Now, we never want to remove an impaled object unless it is blocking the airway, or in a cardiac arrest, it's interfering with chest compressions, or basically our upper airway. So if we had an object in the airway, well, if it's essentially, the key to remember is this: if it is literally impossible to ventilate the patient under all means necessary, every single means that we have, impossible as a paramedic, and you cannot ventilate the patient, and you have a 30-minute transport time, and you could ventilate the patient by removing that impaled object. This is what we're talking about. Again, follow your local protocol, but we're talking about test questions, talking about scenarios, is what we're talking about, okay? That might be a time to call med control, etc., right? And again, interfering with chest compressions. Well, if you're a cardiac arrest and I can't provide CPR, which is the number one chest compressions, which is the number one way to get this person back, we may have to move the object. Okay, so these are two things to think about for test questions. Blocking the airway, chest compressions, the only time we would move an impaled object. Okay, pretty cool? Let's move on. Now, I mentioned this earlier, so I want to make sure we do cover this. Clavicle fractures. Did you know that clavicle fractures are the most common fractured bone in children? That's pediatrics. Now, let's go over 3 pearls here I wrote down. This can happen when a child falls on the shoulder or an outreached arm. So, folks, this may not have happened to you before if you're young, right? But we see a lot of fall victims in EMS, right? If you are literally falling, the instinct is to put your arm out to brace yourself. But what can happen is we can break our arm, again, we have the clavicle, or break our wrist as we do that. Even older folks, right? We think about that. Now, why else is the most common fractured bone in children? Because of sports. Children are in sports. This can also happen in athletes in contact sports. And there's so many sports that children are doing, right, in contact sports. So that is number 2. Next, an isolated clavicle injury is not usually life-threatening. We just want to make sure that bone doesn't pierce or puncture anything else around it. But if it's just a clavicle fracture by itself, should they go to the ER? Yes, of course. Get an evaluation, of course. They're going to need some care, some pain management. We'll talk about splinting in a moment. But if it's just that, it's not life-threatening. Shouldn't be life-threatening, okay? It should not be. What are the signs and symptoms? You go to an athlete, my chest, my arm, right? Because, this clavicle bone is sliding across up in the shoulder area. It's right across the top of the chest. Pain and tenderness and obvious deformity to the bone. The thing about the clavicle is, I mean, we can feel it here, folks. It's right across. You can feel it yourself right now. It's very prominent, so we can immediately see deformity. Management. Well, we have a few options. We can apply a clavicle strap if possible, if we have that, or we can use a traditional sling and swath that every EMT learns about to immobilize the affected arm for pain control. And folks, just so you're aware on your documentation and charting, even at the EMT level, EMT may be watching this going, wow, he said pain management, but I can't give pain meds. What do I do? Yes, you can call a paramedic for pain management. Yes, of course. But you should know that ice packs, that a sling and swath, that position of comfort, that is part of pain management control. It's our first level. Immobilizing a fracture is considered the first step in pain control. Now, let's talk about a life-threatening condition with a clavicle fracture. It's very rare, but I'm going to bring it up to you. Okay, so let's say we see somebody with an isolated clavicle fracture, but they're hypotensive. Could this be going on? In rare cases, a bony fragment of the clavicle can break off and puncture our subclavian vein or artery and can lead to a hematoma or venous thrombosis. Essentially, we have internal bleeding, okay, or bleeding that we can see. Now, this is clavicle fracture. The big pro from this, it's a most fractured bone in children. Look for the obvious deformity, pain and tenderness, treat up to your abilities of what you can, whether you're BLS or ALS. For my paramedics watching this, of course, we can give pain meds to this patient. So sternal fracture, I mentioned earlier, I want to cover it for you here. When we have sternal fracture, this results from a direct blow to the chest or a severe crush injury. An example, again, hitting that steering wheel in a high-speed MVA. I have a big pro for you at the end here, so please hang with me. It's very painful, but usually not life-threatening. That is sternal fracture. But can I share something with you? Here's my big pearl. I'm going to skip side symptoms for one moment. I want to go down to management. And here it is. Have a high degree of suspicion of associated injuries that can occur with sternal fractures. Why is that? I mentioned it earlier, folks. If someone has fractured their sternum, you're telling me at the ribs or the clavicle or the lungs or the heart, they were just totally not affected, but the force was so great that you fractured your hard sternum? That's right. So we don't just go, oh, it's a sternal fracture. Folks, you're telling me the lungs and the heart were just not affected? It's not impossible, but it's not probable that nothing else got affected if you fracture your sternum, right? So, signs and symptoms. Significant anterior chest trauma, tenderness, severe pain, okay, very painful. Abnormal motion or crepitus over the sternum, okay? This is what we look for. I am so proud to announce that the Paramedic Coach is now CAPCE accredited, and we're now recertifying your National Rescue certification. So if you're an EMS provider out there and you need CE and you need hours, you need to recertify, we now offer 100% online with me as your paramedic coach. You can do it right here on our website, recertification hours. You're going to see a link down in the description. It will say recertify your EMT, something along those lines, and it will take you to a website that looks like this. Watch the video here. I explain the whole recertification process. You're going to love it, and I can't wait for you to see it. And back to the video. So I did it. I made a list for you. I couldn't help myself. And we're going to break down some of these associated injuries. If we fracture our sternum, what do we want to look for? Had to do it for you. Had to do it for you guys. Had to do it for you. Had to do it for everybody here. So pulmonary contusion, cardiac tamponade, rib fractures, pneumothorax, hemothorax, unstable chest wall, thoracic spine, or fractures in this area of the scapula, aortic or other great vessel injury, and myocardial injury. What does this wrap up to? Essentially, look out for other fractures and watch out for lung and heart injuries and great vessel injuries, which it breaks down to. Watching this video, if you see someone with a sternal fracture, You know it's cold now, you're not gonna miss it. Okay, this one is a big one, and it gets students tripped up, and guess what? It's not gonna get you tripped up anymore. It actually can be rare to see in the field, and I'll explain why in a moment, but they always talk about it on test day, and they always talk about it in class, and it is a true emergency. Here's why. For a flail chest to actually develop takes time. And in the field, you might not be with the patient long enough to actually see it develop. So what I will tell you is, actually see this in the field, your patient's been, for lack of a better word, sick and injured for quite a while. So plant that in your brain. Now, I have a lot to share with you here, so I'm gonna break this down. Here we go. Flail chest. Definition, this is key term, big. 2 or more adjacent ribs are fractured in 2 or more places. It can be difficult to detect in the EMS setting due to muscle spasm that accompanies it. Again, after 2 hours, the muscle spasm subsides. Again, so we might not see it as clear as day as some of the videos you may have seen online of it going crazy up and down. We'll talk about that in a moment. Well, anyway, the hallmark sign of it is paradoxical movement, where we have one side of the chest going the opposite direction than the other. We're supposed to have bilateral chest wall movement, equal rise and fall, okay? So if we have one going one way, one going the other way, we know we might have 2 or more adjacent ribs that are fractured in 2 or more places, and we got a flail chest. So we get paradoxical movement. Sinister finding, got a very sick patient. The flail segment moves inward during inspiration. Big key, jot this one down. This underneath hallmark sign and down, you should pause this video and you should write this down. This is gold. The flail segment moves inward during inspiration. The diaphragm contracts and lowers during inspiration. And that lowers the intrapleural pressure. The unstable chest wall is sucked inward by the negative intrathoracic pressure as the rest of the chest wall expands. The flail segment moves outward. The flail segment means the injured side moves outward during expiration. The diaphragm relaxes and rises during expiration, increasing the intrapleural pressure. The unstable chest wall is moved outward, decreases the effectiveness of ventilations. So this is, when someone says, do you understand a flail chest? This is it right here. So we can see here on the screen, folks, is an example here of, we can see the inhalation, and then we can see the exhalation. Just want to show you a graphic representation of this. We can see here is our adjacent ribs that are fractured. So this would be the side that's actually on the flail segment. Then we can see on inhalation, the differences in pressures, and then on exhalation. So what's our management of a patient with flail chest? Well, the first management piece is to administer oxygen or, if needed, bag valve mask ventilations to maintain SpO2 of at least 94, 95 or higher. External splinting to prevent movement, that can be done. Establish IV access if transport time permits, so ALS, get an IV. Now, I got a pro here. Intubation of the patient if in severe respiratory distress or cannot maintain a normal oxygen ventilation. So what this means here, folks, is if we have a patient and they're in respiratory failure and they're unable to obey commands and their SpO2 is low, their end tidal is not looking good, they cannot control their own airway, they're very unstable with their vital signs. At that point, we may have to, if we have a long transport especially, gain full airway control with intubation. If BVM is not cutting it, we may have to move to ALS and intubate the patient. Now, with flail chest, we want to have a high index of suspicion for pneumothorax. Now, in pneumothorax, I got a lot to talk to you about tension pneumothorax here. But I do want you to know something. There is a difference between a pneumothorax and a tension pneumothorax. And the easiest way for me to highlight it to you is vital signs and the patient presentation. Simply put, folks, if you've got a patient and they're in shock, meaning their blood pressure is under 90 systolic, their mean arterial pressure, their MAP is under 60, they're showing signs of shock, your patient is probably, well, not probably, they are in obstructive shock. Because pneumothorax is underneath obstructive shock. What if we get a patient and they have a pneumothorax, and I'll explain more in a sec, but their vitals are okay. They're probably not in tension yet. Because tension pneumothorax by definition is this: the accumulation of enough air in the pleural space that there are hemodynamic effects. Meaning your patient is not stable anymore, they're unstable. It means now they are in tension pneumothorax. And it's a life-threatening emergency. And that is where, I'm gonna go grab this, we have to use this right here, which is needle decompression, which we're gonna talk about. Hang with me. So, pleural pressure increases as air is leaked into the pleural space during inspiration and is trapped during expiration. Remember, folks, at the very baseline, what do we have with pneumothorax? Well, let me give you a scenario. A bullet enters my chest. Let's just say this is my right hand on my right side, okay? My lung is pierced. What happens now is the lung is in a space called the pleural space. The lung's in a space, okay? If I have air leaving the lung, and what's gonna happen eventually is the air is gonna go around the lung in the pleural space, okay? And what's gonna happen is the lung is gonna start to collapse and collapse and collapse. And eventually what's gonna happen at some point, I am my right lung and I'm collapsing, collapsing, collapsing. Eventually the pressure here from it's gonna be in the pleural space gonna move over. It's gonna put pressure on everything else, like everything in the mediastinum, like the heart, right? And what happens then, since you pneumothorax, we get increased pressure shifts towards the mediastinum, towards the uninjured side. So in my scenario, the right side's hurt and all that air pressure is moving and putting pressure on everything inside my chest, right? Compressing the lung on that side and twisting the heart slightly. There is also compression of the vessels, the vena cava, which is going to do what? The vena cava brings deoxygenated blood that has no oxygen, back from the venous system into the right atria. So if I put that pressure on the vena cava, what's going to happen, folks? Our blood pressure is going down to reduce the venous return to the heart, which decreases cardiac output. And that's how we end up in obstructive shock. Right. Now, tension pneumothorax is most often caused by a closed chest injury. We talked about a way it could be penetrating, but again, most commonly is by blunt. Why is that, right? My example was different. Why? Let me explain. If we get a pneumothorax and it's a blunt injury, the air really has nowhere to escape whatsoever, right? It is literally completely enclosed, which is why we have to actually make a puncture to let the air escape that pleural space. And then what can happen is the lung that was under attack, it can now reinflate itself. This is why we do needle decompression. And this is why we talk about, if you were going to say, Evan, what's the worst pneumothorax? A closed chest injury due to blunt trauma and you're into pneumothorax. Ultimately, is going to be the worst, right? Another way here that can happen, we talked about it, fractured rib lacerates the lung or bronchi. Okay, that fractured rib pierced the lung, and here we are. So here's some pearls. So what are our signs and symptoms? Well, shortness of breath, okay? We talk about decreased or absent lung sound on the affected side. If I got a pneumothorax in my right lung, you're gonna listen here, everything's fine. You listen over here, I don't hear nothing. Okay, on exams, diminished or absent lung sounds on one side, unilaterally, meaning one side, just close the books. It is pneumothorax. That's what it represents as, okay? On one side, we don't hear anything, oh, pneumothorax. The question is it pneumothorax, stable, or is it tension pneumothorax where our vitals and shock is occurring. One of the big hallmarks, maybe you're unsure of it's pneumothorax and you go to ventilate your patient. You're having a hard time ventilating. For my folks out there that manage people's airways, right? If you're managing somebody's airway and you're in control of that, one of our complications of airway management is we can put too much pressure and cause pneumothorax. And man, it's difficult to ventilate, right? So difficulty ventilating with a BVM is a sign of a pneumothorax generally, okay? Again, signs of shock, decompensated, because the vital signs are starting to change, right? Anxiety, high heart rate, hypotension, chest pain. I put a few other ones on here as well that are some advanced things. Subcutaneous emphysema, that's interesting to see. And hyperresonance on the percussion of the affected side. Now, these last two are a late sign, but they're always on the exams. They're always on test questions, so you should know them. You go to a patient, what are the hallmark signs, symptoms of a tension pneumothorax? Unstable vitals, high heart rate, but they got a low blood pressure. They're clearly in shock, okay? They have JVD, they have tracheal deviation, and they're cyanotic. They got bluing of the skin. And, if I didn't mention it, I did it earlier, but just right now again, unilateral, diminished or absent lung sounds on the affected side. Here it is, JVD, late sign. Cyanosis, late sign. Tracheal deviation, late sign. But on exam, they love to bring these up, okay? I think because they're trying to say, look how sick this person is, it's a late sign. So we're a paramedic, we're working in the ambulance. We see somebody with all these signs, symptoms. They have tension pneumothorax. Let's say it's our classic closed, blunt tension pneumothorax, worst case scenario. What do? Here we go. Well, I'm going to switch here and we're going to go and I'm going to show you. This right here is a 10 gauge needle. And this is how we're going to set it up. Okay. Now it says here 10 or 14 gauge. The problem is if you have someone with a large chest, meaning could be muscle, could be fat, the 14 gauge might not reach. So I recommend, see if your service carries ARS 10 gauge needle is the gold standard, okay? This is the best needle, one of the best you can use, okay? 10 gauge I recommend. Now, management. Tension pneumothorax with close trauma. Pressure must be relieved through needle decompression. It's a paramedic skill. It can be performed with thoracic decompression kit or a large bore needle. This would be an example of a large bore needle. So I'm going to just break this down for you. 10 gauge would be recommended, 14 gauge, okay, that's fine, it can work, but not everyone's built the same, not everyone, not everybody is, the same size, so they can have issues there with muscle or fat. Fourth or fifth intercostal space laterally on the injured side. That's one route we can take to place a needle. The more classic route is a second intercostal space anteriorly at the midclavicular line on the injured side. So let's just break that one down real quick. So midclavicular line, I find my clavicle, I look midline. That's the midclavicular line. Then I have to go to the second intercostal space, okay? Remember, intercostal spaces, when you feel, and sometimes you gotta push down hard to feel them. Again, if there's a lot of muscle, a lot of fat in the chest. You wanna go feel down, really, you gotta press hard to feel sometimes. And you're gonna move rib by rib until we're there. Okay, it's the second intercostal space. Big pearl, we're gonna insert the needle on the top side of the rib to avoid hitting that neurovascular bundle, aka the nerves, okay, which run along the bottom side of the rib. Here's our intercostal space, right? We wanna go at the top, we don't wanna go at the bottom, we wanna go at the slide on the top side of the rib. Audible rush of air should be heard once the needle is placed, if you use the proper needle. And confirming the air escaping the pleural space in a present tension pneumothorax. Okay, that kind of confirms what you're thinking the whole time. The patient should show signs of improvement on your monitor. And they should feel much better. Pain should decrease, anxiety should decrease, heart rate should slow down, etc., etc. This is what you're looking for, and this is the best treatment we can have in the ambulance. In hospital, they're going to place a chest tube in this patient for definitive care. By clicking in the first link in the description, you get lifetime access to my Video Vault program. The Video Vault includes over 480 videos of content and now holds over 2,000 National Registry practice test questions. Also includes some really awesome bonuses like worksheets, drug cards that are pre-filled out all for you, community group access to ask me questions, and audio files when you are on the go. The Video Vault will find you no matter where you're at, whether you're an EMR, EMT, advanced EMT, or paramedic student. And my students use this whether you are getting ready for school, in school right now, or getting ready to go pass your National Registry exams. So click the first link in the description right now and get yourself lifetime access to the Video Vault today. I'll see you there.